You have to catch some breath. It's 5 minutes later, but it's hard to interrupt the meeting with your dean. So, well, this is our very first grand round for the department, and I'm very glad we're starting this new tradition. And I think it's going to be a very nice complementary activity for our Monday research-focused seminars. And so this will be more clinical, translational focused event, and it will give a nice platform also for our fellows to present things. They do present clinical research, and from time to time we will be lucky to bring in really great speakers like today. And I don't want to take any thunder away and ask Peggy to come up. She has worked with Vence for a number of years, I understand, and she will introduce him. Thank you.
Well, you're going to have to bear with me while I read his Mr. Bonham's really long list of accomplishments. He is Senior Advisor to the National Human Genome Research Institute, which we all know as NHGRI, Director on Genomics and Health Disparities. He is also Associate Investigator in the Social and Behavioral Researches Branch, Division of Intramural Research at NHGRI. His research and scholarship is at the intersection of law, public policy, healthcare, and genetics. His research focuses primarily on the social influence of new genomic knowledge, particularly in communities of color, and the role of genetics and genomics on understanding racial and ethnic health disparities. He is also the Chief of Education and Community Involvement Branch, ECIB, in the Division of Policy, Communications, and Education at NHGRI. ECIB initiates, develops, implements, and evaluates education and community engagement programs intended to engage a broad range of the public in understanding genomics and its translation to health and importance to society. Prior to joining the NIH, he was an associate professor with tenure at Michigan State University in the College of Medicine and Law. Today, he's going to talk about genomic medicine coming into focus. He will discuss what it means to be genomically literate and challenges the field of medicine faces in preparing patients and healthcare providers for the genomic era. He will explore the question whether certain communities and populations will benefit from genomic medicine, as well as the research challenges presented in addressing health disparities within the field of genomics. On a personal note, many of you know we run this Why You Can't Wait conference about health disparities in genomics every year. Starting our third year, we'll be in Washington, D.C. this September. And Vence has been truly invaluable to Susan in helping plan for the conference. And I don't even think we could have gotten this far and been so successful without his help. So we welcome you, and we're excited to hear what you're going to tell us.
Thank you for everyone that's here today. So one of the things you have to learn when you are giving a talk is how to shift at different times of your presentations in ways to meet your audience. So I actually want to start with a question. If you are somewhat related to the Department of Human Genetics at University of Miami, raise your hand. All right? And if you have really no background around genomics and genomic medicine, raise your hand and feel comfortable in doing that. Okay, all right. So I'm going to shift slightly my talk and make sure we have time to have the kind of conversation that we have with regards to the participants here today. So I want to apologize if some of the stuff is like, well, what's he talking about that for? That's so general. That's so, I know that. But I want us then to get into the richer conversation about how are we integrating genomic medicine into clinical care, and where are we with regards to research. But let me just start with how I came up with my title for my talk today. So Susan asked me last week for my title for my talk, which I had not provided her. And I had just received reviews on a journal article that I had written with several of my colleagues. And it's about how healthcare providers make decisions related to human genetic variation in clinical care. And one of the reviewers said this, and I'm quoting from the review. I think that the integration of personalized medicine into healthcare services is light years away. So when I read that and thinking about the work that we're doing at the Genome Institute, the great things that are going on here at University of Miami, I said, no, we really need to talk about how it's coming into focus. My expectation as reviewer was a clinician, but not someone who was involved in genetics and genomics. And this issue of where are we as a field and how do we move forward in making sure we both understand how others are thinking about the field of genomics as well as where it's really integrated within our society. So let me just start by going through very quickly the way I've divided my talk today. So I want to talk and this is going to fly by, genomics in the news, then genomics research today, where I'll give you some sense of some issues around funding and programming at NHGRI. Will genomic medicine benefit all? And really that's the disparities question that I really would like for us to talk about after my talk. And what does it mean to be genomically literate? So everyone here knows that in 1953, one of the significant scientific accomplishments occurred when Francis Crick and James Watson published their Nature article with the help of friends that identified the structure of DNA. And that was now just 61 years ago. But today, when you think about it, I'm sure you can go down the street, see a commercial on the TV in various ways of how DNA has gotten incorporated into our lexicon and into our culture. Everything from selling shoes, to selling cosmetics, to selling cars, to selling all kinds of things about how the concept of DNA and the structure of double helix is used and integrated. But what does the public understand about that? What does your patients understand about that? And what does it mean with regards to clinical care? So one of the major issues is really the impact that genomics is having on our economy. We've clearly shown that the contributions that your tax dollars for the Human Genome Project has now significantly increased our economy with regards to the growth and its impact with regards to both biotechnology as well as clinical care, which has been shown through work of the Battelle enterprise with the reports that they did. Last year, as you know, the Marriott case was finally decided, a major case with regards to identification of patenting of genes, which will be important as we move forward. And then the issue of GINA, which passed in 2008. So the Genetic Non-Discrimination Act passed in 2008. But actually it was just last year that the first case was decided by EEOC related to GINA. And that case involved a company where they were collecting the medical histories of applicants for positions. They settled the case with the EEOC and had to pay $50,000. The second case was just decided in January of this year, and that case involved a company called Founders Pavilion. And in that case, they settled the case for $370,000 and are required not to collect any more medical histories. So the two cases involving GINA that have gone through the litigation process involve the collecting of medical histories of potential candidates for positions with these two organizations. It's interesting that that's the type of genetic information that has been the focus with regards to the claims. Now, there has been more than 750 claims that have been filed with the EEOC at this time. They are working through the system at this point in time. We'll see how many of those actually come to a point where there's a resolution and a reporting with regards to the actions taken by the EEOC. But these two cases are starting this process of actually using GINA to help to protect individuals related to employment. Now, the other part of GINA is what? Healthcare. So GINA involved two issues: protecting individual employees with regards to use of their genetic information, and protecting individuals with regards to increasing the cost of health care. And genetic information, as you know, is described broadly, but it's not someone that is diagnosed with a disease. So your information about, say, your BRCA mutation status is protected, but if you had breast cancer, that information would not be protected. It's not within Genome. So as we move forward, what other types of claims will come in front of the EEOC? And will they impact the willingness of individuals to participate in research, as well as the issues of clinical care? And one of the issues from the perspective of our institute is really the concern of whether a fear of discrimination will have an impact on individuals participating in research. Francis Collins, along with many colleagues across the country, worked for over 10 years to get this law passed. And now that it's passed, is it making a difference with regards to the willingness of individuals to participate in research? And I'm curious to hear about the experience here at the University of Miami. So last year, the AMA published a report, the Personalized Medicine Report, which was really the first entree that AMA has really made into this question around personalized medicine and genomic medicine and identifying its perspectives and reporting on it. AMA has been involved in a number of the organizations that have been involved, including one that I'll talk to you about in a minute, which is called the Inter-Society, which is bringing together all of the agencies to really think about how genomics is being integrated into healthcare. But I couldn't talk about how genomics is coming into focus and not talk about Angelina Jolie. Because in our area of the world, it really has had an impact on how many women are coming to get tested for BRCA1 and BRCA2 and making decisions. And Angelina Jolie's opinion piece in the New York Times and the framing and the way she did this has really broadened the conversation about risk and decisions with regards to preventive surgery. And so Angelina Jolie has had an impact on how genomic medicine is becoming into focus. So the FDA, 2013 was a big year for the FDA with regards to genomics, and it actually started with their authorizing the approval of the Illumina MiceSeq for actual clinical use and providing approval for that. But the FDA was also involved in something else that has gotten a lot of conversations, and some of the work that we are currently doing with the public. Every time we have a conversation with a sophisticated public about genetics and genomics, 23andMe comes up. I mean, every time. And as I assume everyone in this room knows, that the FDA ordered 23andMe to cease providing the kits and providing information with regards to health because of their failure to respond to requests made by the FDA. And this has been so interesting from the perspective of exploring how the public is thinking about this question of their own autonomy of their genetic information. I don't know if anyone in the room has followed the blogs related to this, but it's been a fascinating conversation on how people are responding to the FDA and the questions of limitations on 23andMe's ability to provide this service. And so as we go forward and think about companies like 23andMe and the direct-to-consumer genetic testing companies, what role will they play in genomic medicine? Will they be gone in 3 years, 5 years? Or will they continue to play an important role because of individuals wanting to protect their information and to actually take control of interacting with their healthcare provider with regards to genetic and genomic information as a first step in a process of making decisions related to clinical care? Ann Wojcicki has had an opportunity to come and visit the exhibition at the Smithsonian. Some of their work is actually within that exhibition related to ancestry. And it's clearly an area where there is a lot of individuals within the general public that are very interested in the work that they do and the ways that they disseminate education information to the public. So we can just spend the rest of our hour talking about this debate. related to the ACMG recommendations for clinical genomic incidental findings. I don't know how many of you were in Nashville, and I would love to hear the backroom conversations that occurred. But again, as I assume most of you in the room know, the ACMG came out with findings with regards to incidental findings, which created a really interesting debate both within the community of genetics and genomics, as well as in the bioethics community, about should they have the ability to opt out? Should patients have the ability to opt out? So, I guess about 2 weeks ago, there was a modification made at the ACMG meeting in Nashville, and now there's a recommendation to opt out as an option for individual participants with regards to incidental findings. This fundamental question about genomics, that we learn so much information. How do we make decisions about what we share with the patient or what we share with the research participant? And who has that right to make that decision? And exploring these questions of what is in the best interest of the participant patient, as well as what is in the autonomy of the individual participant or patient with regards to this. And how is actual clinical care different from a research setting with regards to what you share, and what right does the individual have to say, I don't want that information, I would rather not have that information, and how do we move forward in this conversation? So I look forward to hearing a little bit about some of the conversations that went on in Nashville and how we may want to move forward. So let me focus on research today. And I actually want to focus here on the National Human Genome Research Institute's work and research, as well as work that's going on at the National Institutes of Health. And I want to start with this heat map figure here that some of you I know have seen, that was part of the strategic plan that was published in 2011 in Nature by Dr. Green et al. To help to frame the future of genomics research. And the heat map shows here, during the Human Genome Project between 1990 and 2003, that most of the work that was going on, as well as the accomplishments, were around understanding the structures of genome and understanding the biology of genome. And then from 2004, after the completion of the Genome Project in 2010, it started really moving into understanding the biology of disease, and very little was going on with regards to advancing the science of the medicine and improving effectiveness of healthcare. But you see, it's actually continuing to move. And my argument is this heat map really doesn't show what's happening today. So think about it. Here it is, April 2014, where we are with regards to how genomics is actually becoming integrated into clinical care and is being used in various settings. And our expectation beyond 2020, that really most of our research funding, as well as how genomics is being used, will be much more applied to advancing the science of medicine and improving the effectiveness of healthcare. But my argument and the hypothesis of my title coming into focus, that all of this is happening much quicker than we all expected it to do. That because of the costs, it is getting integrated in a way very quickly, and we are all part of that laboratory and understanding of what's happening, and that we need to study that now while we're in this process. And you are in the perfect environment to do that, to study what is actually getting integrated into clinical medicine. Because of the interest of the medical school in creating the next generation of clinicians that are literate in genomics, as well as the expertise of this department, that you are in a unique position to actually understand and study the environment within the environment as it is occurring. Because we are starting to use genomics in a way that we never expected 5 years ago, in my opinion. So I want to just take a minute and talk about some quick milestones that I think help to see how quickly things are moving. You see here with regards to how sequencing was done over the last 23 years, the cost of sequencing and how that's reduced. You can tell me what your cost is here. It looks like 3,000 to 5,000 is kind of the number that we are using with regards to sequencing. And I don't know what your exome sequencing versus whole genome sequencing cost is, but also the timing of getting sequencing done. And the number of individuals that are being sequenced. I asked for a slide from Dr. Green's office about the number of individuals that we know that have been sequenced. We don't have that slide. And it'd be interesting to know how many have been sequenced here in Miami, how many have been sequenced in Florida, how much data that you can get from the healthcare systems around you here in Miami with regards to actual sequencing that's occurring. So the world is changing, the technology is changing, the model of how sequencing is done, who owns the companies that's doing the mass sequencing. Really, the infrastructure for sequencing is changing dramatically. If you think about 5 years ago, which you expect that companies like Complete Genomics, would now BGI Complete Genomics, would exist and would be doing the majority of the sequencing that's going on in the world, or would that still be in academic institutions? The world is changing around us. The nanopore, the actual sequencing that now will start taking place in the field. How do we think about these issues and how we use this information? All of this data that's being collected that you two know so much, and how do we make sense of all this data? And again, this is kind of our iconic slide of saying that sequencing cost is going down greater than Moore's law. But it really is an important statement of the integration with genomic medicine, is that the sequencing cost, I believe, is driving how it's getting integrated into clinical medicine today versus the potential that we expected to have happen over a 10 to 15-year period of time. So in the second milestone slide I want to share, which I think really does bring this into appropriateness from a clinical perspective. If you look here, the number of genes with known phenotype in 1990 was 53, and now in 2013 it was 2972. Think about that. The knowledge that we have about gene variants related to disease has increased dramatically. Phenotype disorders with known molecular basis, the number of disorders that have been identified and how they've grown, the number of GWAS studies, the Genome-Wide Association studies, which continues to grow on a daily basis, the replicated disease-associated gene variants, and I'll come back to that as I talk about the issues of disparities, and then the issue of pharmacogenomics and the number of drugs with FDA labels, black labels, with regards to the drugs. So this question of GWAS studies, genome-wide association studies, and all of the different variants that have been identified and that have been published over the last 15 years. And you look here at the number of different kinds of diseases that are really included, incorporated in this. This is a world that's changing and is clearly changing in front of us. And so the question is, how do we deal with it? Is this information helpful? Is this information not with regards to clinical care? So I want to take a minute and talk about a couple programs at NIH that I think are kind of leading the way. And I assume everyone in this room would probably agree with me that cancer really is leading our way with regards to genomics. And I think it will continue to lead the way over the next 10 to 15 years. That is where genomics will get integrated in a way that when an individual patient goes in to see their oncologist, they're going to be talking about a genomic analysis to that patient and to that family. And it will help to communicate what that concept means and how it may be important with regards to the care of their cancer. That is here today, and it's only going to grow. And the work that the National Cancer Institute, and NHGRI with regards to the Cancer Genome Atlas project, as well as other projects, have been significant in helping to move that work forward. And I know that you here have been involved in some of that work related to cancer. And so this is the cutting edge, and where we think about how decisions get made, who has the opportunity to benefit from the genomic analysis, who doesn't have the benefit from the genomic analysis is so important as we explore the questions of differences in care that occur in this city and across this country, and how do we address those issues to improve the quality of care for everyone. So another program that I want to make sure you're all aware of. How many people are aware of CSER, the CSER program? Can you raise your hand if you're familiar with CSER? So CSER is a program that's funded by the National Human Genome Research Institute. And this is one of our programs that we have within the Genomic Medicine division of helping to study the actual clinical application and providing this forum and ability to use the clinical setting as a laboratory to study how it's integrated. And this program has only been in existence now less than 2 years, but it's already proving to be a rich opportunity to learn the actual integration of genomics in clinical care. And these articles are just examples of some of the work that's coming out of the CSER programs. And I want to highlight one that I'm going to come back to, and this is the one on the actionable pathogenic incidental findings in 1,000 participants with their exomes. But this work, I believe, is going to be extremely important in understanding how its integration in clinical care. But we actually need many more of these sites and individuals at both individual research grants, R01 grants, as well as program grants doing this kind of work to help us to integrate genomic medicine. And we need sites that are focused on looking at diverse ancestral populations and looking at issues with regards to disparities and understanding and exploring these questions. So as you think about your own research interests related to how genomics is important for clinical care, it's an area of extreme importance is to understand the questions of ancestrally diverse populations and the integration into clinical care. So another program I just want to highlight, which is one that was just funded within the last 6 months, is the Genomic Sequencing and Newborn Healthcare Program. And this is an interesting program from the perspective of how we actually use genomic analysis for newborn screening and in newborn settings of both healthy newborns and individual newborns with medical conditions, as well as the ethical, legal, and social issues of newborn screening. One of the reasons we are involved with this program, along with the National Institute of Child Health and Human Development, is to get out front and to start to study it before it actually potentially becomes integrated into state newborn screening programs. Again, getting back to this question with the cost of sequencing coming down so dramatically, what can we do to be prepared for potentially using genomic analysis in newborn screening? Is that a good thing? Is it a bad thing? If we are going to do it, what's the best approach to do it? And so understanding and studying these issues is extremely important from our perspective. So let me take a minute and talk about genomic funding at NIH. And I have I have 4 slides here. And I have 4 slides because it's difficult to collect data at NIH with regards to how much funding in a specific topic area. So this was created by our staff by going into the NIH Reporter as well as other systems that we have to identify studies, okay? And we have to use search words. And so the search word that was used here was genome to identify the grants. And you'll see here based on actual funding and the number of grants. And the human genome is actually NHGRI. So those are NHGRI grants. And the non-human genome, or non-HG, are all the other institutes and centers that make up NIH. But there is a common theme of this data. So you see here, with regards to the actual dollars that is spent with regards to grants and research that have been funded, where genome is in the search words, it's dramatically higher outside of our institute. That's not surprising, because our institute is really one of the smaller institutes at NIH. Our budget is approximately $500 million. So we are in the lowest quartile of funding at NIH, but we have a big stake. And the number of grants, you can see here the number of grants again. The majority of the funding is outside of NHGRI. So then using the term genome sequencing, and you'll see here, and it makes sense, that actually NHGRI was the greatest funder in funds related to this, particularly in 2005, 2006, but it's going down. And you see other institutes are going up, and the number of grants are going up at other institutes. So what's the message here? Genomics is becoming integrated across all of the National Institutes of Health. It's not just focused in our institute. It's not just focused in NCI. It is getting integrated within the National Institutes of Health, all 27 institutes and centers. The terms genomic or genomics, again here you see the funding is external to our institute and the amount of the funding that has occurred over time. And then final, genomic medicine, which is interesting here because the funding for genomic medicine has been slightly different here from the perspective of the amount of money that's been put into in grants that have been funded with that as part of the search terms. So the message is here that NIH has integrated genomics and genomic medicine across all of NIH, and we are a small part of NIH and the $30 billion that funds biomedical research in this country and across the world. And so as you are thinking about places for funding within NIH, you really need to be looking at RFAs and program announcements across NIH based on the research and the work that you're doing. And those of you that are interested in the social behavioral research or the ethical, legal, and social issues, our institute has been the major funder, but actually other institutes are now becoming significant funders in this area too. So looking at other institutes, there's a great opportunity for research funding and work that you're doing. So, will genomic medicine benefit all? That's my question. So I'm going to take a quick poll. How many people say yes? Raise your hand.
Eventually? We have a time frame? Like
All right, so let me change it a little bit. Will genomic medicine benefit all in the next 10 years? Raise your hands.
Varying degrees.
Okay. How many think that genomic medicine will not benefit all in the next 10 years? Okay. How many think genomic medicine will never benefit all?
When you say all, do you mean the United States or do you mean the world?
So let's just stay to the United States right now. Let's just stay in our country.
How strict is never?
So I think this is the challenge we have. You know, here in Miami, with the diversity of Miami, being at a medical school that serves those that are underserved, this is the question. And as experts in the room in genetics and genomics, this is one of the questions that I think that you need to think about. And that's this question of who is going to benefit. And so I took this quote from Francis Collins that was in the newsletter, Global Health Matters, that the Fogarty puts out, that was published in the fall of 2013. We've enjoyed many successes, and our cause is noble, but not all have benefited equally from the successes of medical research. Disparities persist in health and also in the diversity of our own workforce. So I thought that was a perfect quote for this conversation today, of both thinking about this question of who benefits from medical research, who benefits from the integration of new technology in clinical care, and what are the issues with regards to the understanding of the workforce that actually is providing care to patient populations within this country, and the challenges that we have and the responsibility that we have as leaders and researchers in seeking to make a change. And so I'm coming back to that article that I identified earlier, that some of you are probably very familiar with, and some of you may not. I would encourage you all read this article if you're not familiar with it, because it really raises an interesting and important question. So they studied 1,000 participants, and they sequenced their exomes. And they identified a number of rare variants in a number of the individuals within the study. What do you think the ancestral background of the individuals where they identified the rare variants?
White.
More likely in
Caucasian.
European populations?
More than Europeans.
So this is a statement from the article. The 23 participants with pathogenic or likely pathogenic variants were disproportionately of European, 17, versus African, 6 descent. The process of classifying these variants underscores the need for more comprehensive and diverse centralized resources to provide curated information on the pathogenicity for clinical use to minimize health disparities in genomic medicine. So what does that say? It means if you're not in the sample, you can't be studied, there can't be a reference catalog to help to identify variants. And this is important because the question is what's being missed. Okay? So these are individuals who have access to the technology. They're in this research study. So it's not that they're not having their genome sequenced. They are participating and they're involved. But because of the lack of data, it becomes a problem in identifying rare variants. And this is a huge issue that the field needs to address, and that we have to figure out ways to address it. And so I come to you here in my role as a senior advisor to Dr. Green on health disparities in genomics, and actually say that today I think this is the most important issue in addressing inequities and health disparities related to genomics. The issue of the samples we have, the diversity of ancestral background, and the potential downstream impact in understanding clinical variations of importance. And it's an issue that we need to figure out strategies to address. And so one of the things that I want to ask during our Q&A is, what are some strategies? Do you agree that this is the major issue related to disparities? But I think this is the one that we must address. Now, NHGRI and NIH are seeking to address this with a number of different programs. And one of the programs that is involved in this is the Population Architecture Using Genomics and Epidemiology, or the PAGE program. And it's a program actually to do sequencing and genotyping of individuals of non-European participants and to look at differences related to phenotypes. So we recognize this is an issue and there is funding going in, but we need more, and we need more individuals that are conducting those studies. So it's an area that we need to recognize, and it's an area of importance that I think as genomic and genetic experts that we really need to struggle with, is this question of who's in our studies, who's not in our studies, how do we make sure we have the appropriate sample sizes within our studies, and how we explore this issue. It is a challenge that we need to take on, and I look forward to working with the University of Miami to help to take on that challenge. But you also have to talk about the elephant in the room, right? There's always an elephant in the room, and you have to address the elephant. And so in this cartoon it says, I'm right there in the room and no one even acknowledges me. So there is an elephant in the room when we think about genomic medicine and its importance. And one of them is access. Who has access to the technology? Who has access to the services? And the issue of cost. These are real. They are important issues that we have to think about as a field, and how do we bring this new technology into clinical care, and how do we make sure all of those that can benefit from it have the chance to benefit. And so the elephant is in the room, it's recognized, and we need to address it. We need to study it. We need to study different populations. We need to study how do we incorporate different populations into the work that we're doing. This is an opportunity to really come up with new strategies of working with diverse communities around these issues. So both the issue of who benefits because of who's in the research, as well as the issue of how do we make sure people have access and address the issues of cost, are important issues of health disparities that we must face within the field of genomics. So I don't know how many of you had a chance to see the Presidential Commission study on bioethical issues that came out related to incidental findings. And it has a number of recommendations. And it's gotten various perspectives from scholars and scientists in the field. But I want to highlight just one recommendation for you today. And it's recommendation 5 that deals with justice and fairness in health. And it says this: the principle of justice and fairness requires that all individuals have access to adequate information, guidance, and support in making informed choices about what medical tests to undergo and what kind of information to seek and what to do with the information once received. The principle of justice and fairness also requires affordable access to quality information about incidental and secondary findings before and after testing, which when coupled with access to care can be potentially life-saving or life-enhancing. So the question of inequities and access are not just with regards to access to the technology and services, but what happens in the follow-up. And again, this is another area for study and an opportunity of how you communicate information about incidental findings to different populations, how different cultures understand, how different family structures understand that issue, how people interpret and use information. And so we need more work to understand these issues. So what does it mean to be genomically literate? And I want to talk just briefly about health professionals and this issue. This is a huge issue, and the leaders in this room clearly know this because you guys have taken on this new genomic medicine program with the medical school, which I applaud, and I want to learn a lot more about. Because the question is, should this be replicated in other parts of the country, and what role should NIH have in this? But there are a lot of eyes in Bethesda looking at what's going on in Miami with this program in a positive way and seeing what you're doing here. Does it have the potential of really helping to integrate genomic medicine into clinical care for the next generation of clinicians? So the work, I'm excited to be here. Eric knows I'm here, and I look forward to taking back to Terry and Eric what I learned here over my 2 days. So I did a study with general internal medicine physicians where we studied the internists to understand their knowledge of genetic variation, how they use genetic variation in their practice, and how they associated genetic variation with race and ethnicity. But we also asked a lot of questions about patients coming to their clinics with direct-to-consumer genetic testing reports. We asked questions about the issues of what tests they order, their referrals, but we asked them the question, how would you rate your knowledge of genetics? And you see here the majority of the physicians, internal medicine physicians, reported their knowledge as either fair or poor. Okay? This has been shown in a number of studies by a number of scholars and scientists across this country that clinicians are not prepared. They perceive their knowledge as poor. And so how do we address this issue? And how do we address this issue for physicians who are currently in practice? And how do we address this issue for new clinicians going through the training process. And so one of the things that our institute has been involved in, and I think the Vences have been up to one of these meetings, is that we've established a genomic medicine working group. And that working group is helping our institute in highlighting what we as an institute should be doing in this area. And we recognize that this is an important area for the actual benefit of genomics for clinical care, and understanding that. And so we also recognize we're NIH. We're not the societies and the organizations that govern our clinical enterprise. And so one of the things that we did with this working group was establish the Inter-Society Coordinating Committee, which is made up of healthcare organizations, to bring them together to talk about what is needed in developing practices, appropriate competencies to provide so that they can then provide that back into their various societies and organizations. And it's to facilitate professional societies' efforts in educating physicians and other practitioners in the use of genomic medicine and clinical care. So we recognize this is important, and Dr. Terry Manolio is leading this for our institute, but there are a number of parts of the institute involved, including our Genomics and Society division, which Dr. Larry Brody leads, and the Division for Policy, Communications, and Education that I'm a part of, that Dr. Laura Rodriguez leads. And this issue is an important one, but trying to figure out the best ways to provide information to help to enhance knowledge is not an easy one. So there have been several reports that have come out of the Inter-Society Coordinating Committee in its short lifespan so far. And these reports are continuing to move forward, and publications are starting to come out related to this. And I encourage the involvement of the faculty here at the medical school in helping to frame and think about these questions because of the importance that you have recognized of this issue. But we are at this point of trying to figure out how do you build the bridges, how do you create the relationships, how do we move forward with regards to bringing genomic medicine into the infrastructure of education, of health professionals, particularly of physicians, from my perspective, that we need to address. We're also doing work with nurses, genetic counselors, physician assistants, but you know, one of the hard nuts to crack is actually physicians and how do you integrate genomic medicine in a way that is appropriate and at the appropriate time with regards to clinical care, and so addressing those issues. So I want to close my talk talking about the public and the issue of genomic literacy for the public. And I want to start by highlighting a report from a meeting that we held on the public and genomic literacy and what were some of the major things that we need to do. I would encourage you to go to this report. And we identified that one of the things we actually need to do is come up with a good assessments and measures so that we can have some common measures that are used across different research studies to explore this issue around genomic literacy of the public and bringing different people together in a way and a model to help to study these issues. And so we have taken that on as a responsibility. And one of the things that we've had a great opportunity to be involved in over the last 2 years that is part of our genomic literacy activities, where we're actually conducting research as well as public assessment and development of various ways to engage the community, is around a partnership that we have with the Smithsonian Institution and the National Museum of Natural History. The National Human Genome Research Institute entered into this partnership now a little less than 3 years ago that I've been pleased to help to lead for our institute, where we've developed now an exhibition. It's a 4,000 square foot exhibition that explores genomics. Genomics in the natural world, genomics in ancestry and history and genetic variation, concepts of genetics and genomics in health for the public. More than 1.6 million people have seen this exhibit since it opened at the Smithsonian last June. We expect before it leaves the museum in September that over 3 million people will have seen and interacted with this exhibit. And this is one of our ways of outreach and education of the public, of bringing actual knowledge and programming to go along with it. And so we've had programs with postdocs and our investigators where we have brought scientists in the museum to have conversations around genetics and genomics. We have had public programming on the African diaspora, ancestry, genomics, and culture that we've done in partnership with the African American History and Culture Museum, the Smithsonian. We have a program coming up with the Brooklyn Library in Brooklyn, New York as part of this program with the Henrietta Lacks family coming up on the second week of May and exploring issues with regards to HeLa cells. We have a program with the National Congress of American Indians and the National Museum of American Indians the end of June, where we're bringing Native researchers and conversations about genetics and genomics in tribal communities. We are seeking to reach out broadly to diverse communities. We have student groups coming in. We have senior groups coming into the exhibit and being exposed to this environment. And we also have the public interacting within the exhibit. And it really is an opportunity. If you're going to be in Washington, D.C. before September 1st of this year, I strongly encourage you to go to the Natural History Museum and visit the Genetics and Genomics exhibit. If you're not going to be there, but you're going to be at ASHAG in San Diego in October, it will be there. It's traveling to the Fleet Science Center in San Diego as its next stop. It's going to travel the country in North America for the next 4 to 5 years. So hopefully it can come to Miami before it's done. And when you think about the public, there's all types of public. And I was so pleased to have an opportunity to tour through the exhibition a public that is part of the public that we have to communicate to, and that's policymakers. And this is Congressman Slaughter, who is from New York, who was the leading Congress member on GINA. And having an opportunity to actually tour her through the exhibit and to interact with her within that environment. And our outgoing Secretary of Health and Human Services, other members of Cabinet, other leaders within our country have been through this exhibition. So it provides a forum and an opportunity within a community to have those conversations. So I want to close with something that just recently happened. And if you read Genome Web on a daily basis, you may have read this yesterday. And this is, again, bringing this to focus and talking about genomics. So in March of this year, so about a month ago, the Attorney General from Hawaii, anybody has heard about this? No. This is genomics coming into focus. So the Attorney General in Hawaii filed a lawsuit alleging on the behalf of the state of Hawaii that the makers of Plavix have been deceptively marketing and unfairly labeling Plavix since its launch 15 years ago by failing to alert consumers that the drug has a diminished or no effect on approximately 30% of the population of Hawaii, individuals of Pacific Islander and Asian background. Think about this. This is genomics. This is bringing genomics into focus. The issue of populations and subpopulations and understanding risk, understanding benefit of drugs. So you have an attorney general bringing a suit saying you should have marketed this differently in our geographic area because you know who is in our geographic area. This is genomics coming into focus. So with that, I want to say thank you. I'll take any questions. I'm pleased to be here today, and thank you. So any questions? Yes?
Well, I have a question. So it was, I like very much your heat map, and especially the one you said, this is what we want. So you want to move the hottest part of the heat map to the right. Then I was surprised when you showed the graphs of so there were 20 grants. So in last year, and 18 the previous one on genomic medicine. So if this, what NIH wants is to move the heat map on the right and to promote the benefit of all. Do you think that 20 grants last year and 18 the previous one on genomic medicine, is that a...
So again, these were search words, okay? So there's a lot more grants. Let's just deal with this. Let me start because I know this is being videotaped. So let me make two comments. The search words. So we don't all, and that's why this data is not real good, because so we tried to cover all the search words. But I think the answer is yes. You're absolutely right, and I think that my director and everyone say we will and we must do more that's focused on genomic medicine, on clinical integration. But we also have to continue to understand the structure of genomes. We have to understand, interpret the information. So we have to maintain and develop the basic understanding, but we have to move much more to applied clinical integration. And that is the challenge of what we have. But you're right. I don't disagree with that comment. Yes?
Well, thank you for this very wonderful talk. So I understand GINA is a major milestone for us. Since giving your background, do you think there's an urge that we need more legislation in this area? And if so, and I somehow feel like you would say yes, what is the, kind of from your point of view, what's the most pressing things that...
So the question was, GINA's now law, what other legislation do we need at this point in time? So I actually don't know. So I'm here representing my institute in the federal government, so I'm going to be also very thoughtful in kind of what I respond. But I don't know if it is legislation that we need. I think we need regulations. I think we need guidance. So when we think about the policy issues, it may not be laws. It may actually be the actual implementation of laws that we already have, as well as guidelines and practices within clinical care. I think those are the huge issues from my perspective. I do think now that the FDA and FTC are becoming much more engaged in the issue of genomics. That's a good thing. And how that gets regulated in a way that helps to benefit making sure quality care is provided, but also does not hinder new technology, I think is the challenge and the tension that we'll have over the next few years. And so I think it's all about the regulations versus the laws. Other questions? Yes?
I really enjoyed your talk, but I was thinking about the fact that health disparities have existed long before genomics were in place. And it seems that we haven't really had a great deal of success in addressing them. Why do you think I know it's important, but what is it that's going to be different when it comes to genomics and genetics with respect to disparities?
No, I think that's an excellent question, and I think some of it will not be different. And, I don't know how many of you have had a chance to look at the Institute of Medicine's report called Unequal Treatment. It's actually now, 10, 12 years old? It's old. But it's still good research on the disparities we have in treatment that exists across various settings and various clinical conditions. And I think that we're going to have that challenge with genomics. I think what's different about genomics is that it is focused on the individual and personal, as well as then it's focused on populations, okay, ancestral populations, which makes it, I think, unique and different with regards to disparities questions and understanding that. So again, going back to my issue of who's not participating in the studies, who are not being recruited into the studies, is a disparities question. And that's different than the question of, who's offered certain tests or who's not offered certain tests. And so I think that's a fundamental difference with genomics that we as a community can get right if we work at it right. So I think that's one. And then I think, based on all the great research that has been done about inequities and disparities in our country, that we should learn from that with regards to actual integration into clinical care. and that we should not have to repeat all of the issues, because some of the issues are clearly, directly linked to issues of access related to actual costs, but a lot of them are other things that are going on. And so what can we learn from that research so that as this new technology gets integrated into clinical care, that we avoid those same experiences?
You're right. I attended several of the meetings that Terry's organized about genomic medicine, and also education and how to get individuals educated. And one of the things that's clear, and I think you just brought it up, was that NHGRI's mission still is to educate people in genetics to handle data and big data and all the data that's coming out. And there wasn't clearly at the time a channel for educating people to use the information. But in looking at your graphs of who's getting grants, has there been any thought to moving this to a multi-institutional effort? Because it really affects all the institutes they're all using genetics, and they all will benefit from educating physicians. Is there any move towards?
So I think I would say this: there is a new emphasis within our Genomics and Society division, which has the ELSI program, the Ethical, Legal, and Social Implications program, to develop stronger relationships with other institutes. Historically, since the ELSI program has been in existence at the National Institutes of Health, our institute has funded that. And so we've funded scholars who have done work in that area solely almost. But under Dr. Larry Brody's leadership, I expect that that bridge is being built with other institutes. And the issue of education and research related to how do you teach doctors, what are methods, what are measures, what are ways, that's within the scope of that portfolio. And so I think that there are going to be great opportunities to work across institutes to do that work. And so thinking about, say, cancers and how do you prepare oncologists, or how do you prepare the general primary care provider who's involved in initial screening. I think those kinds of opportunities are going to increase. I think there's other issue with regards to how do we prepare the health professional generally. I think that's a struggle for NIH, because that's not NIH's mission, and so one of the questions is, how do we work with HRSA? How do we work with CDC? How do we work with societies to help to do that work? And how do we work with organizations that are being developed that are taking that on as a responsibility? I think what I would say is our institute recognizes it's an important issue and seek to be a stimulus in helping to bring people together to do that work. So I'm an optimist. So I think that there are some real opportunities, and there is a recognition that this is an important area with regards to actually to really improving the health and reducing the burden of disease, which is part of the mission of NIH. Any last question? One last question? Well, I just want to thank you for your attention, and I'm pleased to be here at the University of Miami. Thank you.